Hello, everyone. I'm Marcela Garcia, and I'm an editorial writer and member of the editorial board at the Boston Globe. Welcome to this Globe Up Talk on immigrants and coronavirus, lessons from the Chelsea Hotspot with Dr. Joseph Betancourt, Vice President and Chief Equity and Inclusion Officer at Mass General Hospital. Globe Up Talks is a new series of conversations we have launched in which members of the Boston Globe editorial board interview thought leaders and unique voices. I'd like to welcome our guest today, Dr. Betancourt, whose field of expertise is the pervasive racial and ethnic disparities in access to healthcare. Dr. Betancourt actually asked Mass General Hospital to establish a center to study these barriers about 15 years ago, if I'm correct, and thus was born the Disparity Solutions Center. So in that way, Dr. Betancourt was in prime position to look at early data on COVID-19 infections and hospitalizations and realize perhaps before anyone else in Massachusetts that Latinos are overrepresented as COVID-19 patients at MGH. Right now, they represent between 35 and 40% of MGH patients, when regularly Latinos account for less than 10% of MGH patients, correct? So because of many socioeconomic factors, the city of Chelsea quickly emerged as a hotspot. And for those of you who don't know, Chelsea is a tiny city of about 2 square miles and about 40,000 residents. It is among the smallest cities in the state, if not the smallest one, and one of the most densely populated. It's also one of the most Latino-heavy municipalities. After Lawrence, up in the Merrimack Valley, Chelsea has the second largest Latino share of the population statewide, with 66% of its residents who are Hispanic. And then, of course, we know that a vast majority of Chelsea residents are frontline workers, janitors, supermarket employees. They rely on public transportation, buses primarily, the 111 bus. So I like to call Chelsea the city of the Latino immigrant, and of course, many of them do not have legal status. So all these factors basically conspire, and Chelsea now has had the highest rate of incidence of infections of COVID-19 in the state by a lot, and it has been brutal. As of yesterday, there were over 2,150 confirmed cases with about 100 fatalities. And that puts Chelsea's rate of infection, it's more than 6 times the rate of infection of the state. So with that being said, and before we get into the lessons and the main topic of our conversation, Dr. Betancourt, thank you for doing this. But let me start by asking you, how do you assess the curve of infection in Chelsea at this juncture?
Yeah, so Marcela, first of all, thank you so much for having me. Thank you for your excellent coverage of this topic. I think it's been something that has required that attention, and we've learned a lot. So I want to thank you and the Globe for giving it the attention it deserves. There's been a lot of stories on this, and so we are appreciative. I think there is some good news, but we're always cautious with good news because the concern about giving too much good news is that people begin to pull back from the responsible behaviors that we really need people to continue to follow. And with Chelsea, certainly, we have seen a flattening of the incidence rate. If you look at the last week or so, it's been in the low 500s per 10,000 population, whereas it was climbing, I think when we started, the first number we got was 73 per 10,000, and then started climbing almost 50 to 70 per 10,000 a day as we began to do more testing. We have certainly seen a flattening there. And here at Mass General, we track the cities and towns that people are admitted from, and we've seen a significant decrease in the amount of individuals from Chelsea who are admitted to our hospital. So definitely good news, but there's no doubt that this community was hit hard. It was hit early. It spread fast. And I think there's a lot of lessons to be learned. For all the reasons that you mentioned, I think we understand why that happened. And I think now it's what do we learn from this? But definitely, I think we're turning the corner. Still, a lot of work needs to be done in Chelsea. There's going to be communications around contact tracing, because as you're on your way down, you need to prevent these little brush fires from happening. And so contact tracing, which I'm happy to talk about later, will give us a chance to really take more deliberate efforts as little breakouts occur. But we're headed in the right direction. Matter of fact, today we found out that there was only 15 confirmed new cases today in Chelsea and no deaths. So that's news that's hot off the presses, and that's real progress. So we're hopeful.
Well, that's interesting. I actually, before we joined the call, I was checking because the city of Chelsea has actually been very good at updating its residents through its website, and they post around this time. I think, in my experience, they've been posting the daily rates or the daily cases, and they hadn't so far. So thank you for that information. Sure. So talking a little bit about the lessons that Chelsea offers. So what effective measures do you in your view, have been put into place there that you think have moved the needle and have put us into this, flattening of curve?
Yeah, well, let me begin by saying that the city of Chelsea, the city manager, Tom Ambrosino, his entire team, all those individuals who have been doing incredible work in Chelsea for a long time, those individuals, I think, really rallied very, very early on to this work. And so the credit really goes to them for, kind of sounding the alarm very early and taking some legitimate action. We started doing expanded testing probably April 1st at our MGH Chelsea respiratory infectious control setup there. But really there are 4 pieces that we started to focus on with them, with their leadership, with their guidance, and with partnership from the state, certainly that allowed us, I think, with them to make a big difference. And the first one is exactly that, testing. The first of the 4 pillars that we focused on was identification. So we knew that in Chelsea, we needed to do a better job of testing more people and expanding the criteria. We had pretty strict criteria because as a state and as a nation, we haven't had as much testing as we'd liked. So we couldn't, not just us, but around the country, just test anyone at any time. But we were able to loosen the criteria in Chelsea, get it hotspot designation at our health center, and begin to do more testing. Number 2, we quickly realized that given all the social conditions that you described, if we tell somebody to socially distance or socially isolate, yet they're in a home where they're taking care of other family members, not unlike we see in other communities, but perhaps in a smaller space, then it is more difficult for people to socially isolate or socially distance. So we created these things called care kits that we were able to deliver both at our health center, to food pantries in collaboration with the city, even door to door. And boy, over the course of 1 week, I think it was from April 13th to April 19th, there was about 25,000 masks, about 6,000 kits that were delivered. We're now up to 17,000 kits, about 66,000 masks. So in those kits, you get a mask, you get information in English and Spanish, you get some information on creating cleaning solutions, some information on how to wash your hands, either soap or hand sanitizer. The idea is that in the absence of our ability to change your social conditions, what can I give you to make the most of them? And those were the care kits. The third is isolation, and I know we'll get a chance to talk a little bit more about that. But Boston Hope, the Quality Inn and Revere are examples of places where if we find somebody is positive and they can't protect their family members at home because of crowding, because they can't guarantee that they won't spread it, these are places that have been created for people to go convalesce. It's staffed by healthcare professionals so that they can protect their families and protect themselves. And then the fourth part is just this communication piece. So first it was checking in on people with symptoms, checking in on positives. Now we're moving towards the state and partners in help with contact tracing. So those 4 areas, identification, mitigation, isolation, and communication, I think have played a significant role in what we hope is a contribution to decreasing the pandemic in Chelsea.
Got it. So given, one question in people's minds, I think, is that given the vulnerability of this population, all these factors, the large undocumented population who's primarily Spanish language speaking, large percentage of people who are deemed essential workers, the density of the city, the housing conditions, like you were saying, I guess the question that looms in people's minds is why wasn't this outbreak anticipated earlier?
Yeah, it's a great question. And I think, it's interesting. We formed our efforts here at MGH and at partners to focus on equity on March 16th. And a lot of that was focused on being prepared as a healthcare system to make sure that anybody received, regardless of who they were, where they're from, what language they spoke, we were prepared to meet their needs. On the public health side, on our Center for Community Health Improvement and our community health leaders, and the city really, I think, began to focus a lot on this understanding that all these social determinants of health, food insecurity, issues are related to safety, issues related to paying for utilities, rent, job insecurity. All those factors were going to be exacerbated by this pandemic, and so a lot of focus very early on was put on those very important community health factors. But there's no doubt that this is a pandemic that nobody had ever experienced, nobody ever thought about. So I want to acknowledge that we learned quickly, but as I look back, I think we could have, and I hold myself accountable here, we could have predicted that given the science of this virus, the fact that this virus is easily spread in asymptomatic ways, when people don't have any symptoms at all, with the set of social conditions that create the perfect storm for spread. I believe that if we were to have another chance at this, the second we hear a sniff of a pandemic that may have a global impact, we need to, based on those sets of social conditions, identify hotspots, because we know where they are already. All the ones that are leading in the state right now have those sets of social factors. They are compounded by language barriers, by issues of mistrust and not having trusted messengers, and certainly by issues related to immigration status. But this is Queens, New York. This is New Orleans. This is Detroit. This is Washington, D.C. These are not unique to us. And I think on the next go around, we need to, at the first sound of the alarm globally, it's to go in there because the social conditions in which these individuals live is the perfect storm.
Yeah. So going back to, or just piggybacking on what you said, if we could replay, like, let's just for a second engaging, what if, like, if we have this, time machine and if we could go back in time, beginning of February, what sort of measures should have been in place? What is an ideal public health setting in Chelsea looks like at that point in time? And also, how would those measures reflect the residents' cultural expectations about healthcare? Because this is your basic area of expertise. You worked in, disparities. So what does that look like back then?
Yeah, and I'd say these lessons learned aren't just local. They're federal, they're state, and they're local. Because I think the same hotspot strategy that we deployed in Chelsea could have been deployed in a lot of different areas around the country. So what have we learned? This does come in waves in certain areas. We absolutely learned that this hit early in communities with those sets of social conditions. So, as I reflect back, we started our effort March 16th. A couple of days before that, I had gone down to talk to our food and nutrition, environmental services workers, just about what was coming and kind of giving them information. And they were already talking about, oh, but boy, I need to get on a crowded bus. Boy, I saw the recommendation was to not wear a mask. Shouldn't I be worried? And I look back at that a lot, and I feel like this is how we create mistrust. When we kind of change the script now, and once there are these major fires in certain places, then we say, oh yeah, everybody should wear masks. These communities feel sacrificed already. They're like, we were the canary in the coal mine. Yeah. So I think if I were to go back, I would have thought a bit more about the science and said, there are a set of social conditions that aren't particularly linked just to race, but that are social conditions. However, minorities are more likely to live in those social conditions, but that there are a particular set of social conditions and factors that you mentioned: transportation, essential workers, population density, perhaps crowded housing, that make create the perfect storm for the spread of this virus. So with that in mind, you might be able to look at your state and say, these 6 or 7 are a recipe. They have the social conditions that are going to lead to spread. And at that point, you begin heavy communication. And I think, Marcela, that's been a big gap, is we built a lot of stuff and kind of communication has either gone at the kind of in sync or followed slowly. Communication has to be the first thing. Loud, clear, trusted messengers. The second is, if you have 1,000 tests in a state, you really are just going to, you are going to disproportionately target them to these hotspots so that you can quickly identify if that hotspot is emerging and then do contact tracing. I think mitigation efforts were something certainly that I think we could have said, maybe it's not a recommendation for everybody to have masks, but if you have a certain set of social conditions and you need to take the bus or the train, it's crowded, and boy, this thing spreads with a cough or a sneeze, it's common sense that giving these people masks, even early on, makes sense. So those are the things. I think we would have done a lot of what we've done, but just done it way, way earlier. And that's a major lesson learned. And I think, hopefully we won't make those mistakes again. I don't want to, I think everybody who's invested in this work has cared deeply, has been very passionate. So I don't want to make it feel like anybody was asleep at the switch. And I certainly care deeply about this. But I look back and said, man, we probably should have been able to predict that. We were predicting it maybe in a different way, and focus more on ventilators and bed capacity.
Sure. And
not understanding that really the way you prevent the use of ventilators and filling your hospitals is by public health approaches.
Sure. And I definitely want to touch on the communications angle later. But before we get there, I want to ask you about something that I discovered early on when I started reporting on Chelsea. And that's the issue of stigma around the disease. People not acknowledging that they have the disease or that they're sick, kind of like preferring to be in denial, not for the sake of, ignorance or just being in denial, but because their conditions, they didn't have anywhere to go. They didn't know where to isolate. So, this is sort of like a two-part question. To what degree has that sort of stigma has been a factor in Chelsea in the spread of the disease? And second, what kind of public messages or messaging, are effective at fighting that stigma? How do you break through that?
Yeah. So there's no doubt, anecdotally, we've heard about stigma clearly. I just heard something about it today. I think stigma comes out of fear, right? And part of the fear, I think a big part of the stigma was, if I'm sick, they won't let me go to work, right? If I'm sick, I have to be a pillar for my family. I won't be able to care for them. So this stigma is based in a lot of different things, and being strong and needing to kind of battle through. These are resilient people with a lot of grit who don't want to be held down and try not to be held down and do everything they can in the face of a lot of adversity. So you would understand what that viewpoint is going to be. And certainly that stigma of I'm contagious. they're not going to allow me to go into work. I would say that stigma is not just stigma for stigma's sake. There's legitimate fears and concerns about that. Add to that issues related to immigration status and individuals who maybe aren't documented. This virus has demonstrated, and we've said this from the public health standpoint for a lot of years, that viruses don't discriminate by who has papers and who doesn't. And, thoughtful public health is really about protecting ourselves. And you could go in the back there right now and you could have somebody who's busting your table who's from Chelsea or who's from Revere. Papers, no papers. I think the principle here is that we take care of ourselves as a community. And so I think part of that messaging, getting to your second part of your question, is letting people know that we help each other by helping ourselves, by acting responsibly. But I think that the big point is here, in the absence of a trusted messenger, misinformation fills that gap. We heard a lot of it early. And I think when we consider our communication strategies, they're not via email. In certain communities, it's WhatsApp, it's Facebook, it's lowest common denominator technologies. And quite frankly, it's having the courage to move quickly and to use maybe non-traditional sources to enlist trusted messengers who could, look like people, speak their language, understand their culture. I think those two things help address stigma, and they help get people the right information fast. And I think that's also a key lesson that we've learned here.
So one measure that has been put into place is the designation of a hotel, the Quality Inn in Revere you mentioned, for folks to live temporarily, free of charge, people who are unable to isolate due to their housing situation, right? But by and large, that hotel has been underutilized. What do you make of that?
Yeah, it's interesting. I mean, we look at Boston Hope as the same, and the hotel. So let's look at two examples of places that were created with all the best intentions, and I think incredible efforts by the state and the city to create capacity, number one, and number two, a safe place for people. So if we think about, Boston Hope, about 1,000 beds, about 500 for individuals who are homeless, incredible service, 500 that are used for people to convalesce, sections for people who are positive. The Quality Inn in Chelsea is a collaboration led by the city manager of Chelsea, the mayor of Revere, now involvement from Lynn and Somerville. And the idea is, very thoughtful. We're going to put our money in here, get this Quality Inn. We're going to give people a chance to convalesce safely, protect their families. We're going to feed them. We're going to have nursing staff there. It is a comfortable place. Incredible teamwork, MGH staffing, the one at Chelsea, the one at Revere, Boston hoping, staffed by multiple people. So a lot of great intentions. But the challenge has become, how do you normalize this for a community? I mean, home is always the best and safest place for anyone. Everybody always prefers to be home. And so the second is, then you hear rumors about, what are these places like? Are they comfortable? Are people going to understand me? Are they safe? Am I going to be held a prisoner there? And all these rumors start to kind of circulate around. And, we don't utilize these to the max of their capacity. And so this idea of, if you build it, they will come, without communication isn't true. And I think we're getting better. We're up to about upwards of 50 some odd individuals in a Quality Inn that has about 148 rooms. We've had up to 75 individuals there, in and out, with
Well, that's better.
being in distress. So we're getting there, but that messaging is really critical. And Boston Hope has faced some similar challenges.
Okay.
So I'd say, nobody doesn't want to be home. And unless you make that not home place very appealing and let people know that the reason, we're going to treat you well, you're going to get fed, and you're going to protect your family, unless you message that, it's always going to be an uphill battle. And so, we're in that battle now.
So let's go back now to the communications piece, because obviously, a pandemic is, the response is basically just all communications, right? So given how this population in Chelsea, immigrants and Latino immigrants, they tend to find news definitely not from mainstream news sources, WhatsApp, or even, Spanish language TV news stations like Telemundo, Univision. Are there models out there that have, and you briefly touched on this before, but if you can just expand, are there models out there that, have successfully reached these sort of populations? Can we point to any kind of system or place? Like you said earlier, there are many Chelseas out there, right? Queens, New York, et cetera. That's, effective at reaching this population. You mentioned earlier having a trusted figure, and I've thought about this a lot, that I think it would have been very effective if there had been a trusted Latino figure who did something equivalent every day, as the news conference that Governor Baker and the Mayor Walsh does, that since the state of emergency began, there would have been, would that have made a difference, is what I'm trying to get at. And again, you mentioned this earlier, if you could expand on that.
Yeah, I'll say that we had the good fortune of engaging many of those multicultural media partners, because at the end of the day, I don't believe that we need to reinvent the wheel, right?
Sure.
There are trusted sources there. So we've worked very early on, we worked very closely with El Planeta. We just did a lot with El Mundo. So, they have a strong presence. Telemundo and Univision too. And so I think those have been partners that have been very helpful. Of course, I think we've wanted to do more with WhatsApp, which is commonly used in Latino communities as well. We've done Facebook Live. So I think, we have trusted vehicles and sources there, people like yourself and others who are well respected and understood and trusted by the community. I think it's turning it around, as you mentioned, quickly, and not in an ad hoc way, right? Not covering a story as a story emerges, but the steady drumbeat of messages to the community. I think you've hit on it just right. I mean, I as I look back, I think, as opposed to being in a reactionary mode, being more proactive and saying, every 2 days we're going to do a Latino press conference where we're going to do this in Spanish. We're going to let people know what's happening, give them the latest advice, and people would really tune in for that. So again, another major lesson learned. Those partners do exist.
Yeah. So now let's look way into the future, right? In a post-COVID emergency world, how concerned are you about access to healthcare for this disenfranchised population? Are you concerned that this epidemic is going to exacerbate this healthcare inequality, this pre-existing healthcare inequalities? For instance, how do you begin convincing disenfranchised populations like Chelsea's to show up to their appointments once it's safe to do so, right? Their healthcare appointments. What is the plan? What does the plan look like to get this message to Latinos?
Yeah, so I break this up into 3 areas. I break it up into pre-COVID status, kind of contemporary COVID status and post-COVID status. In the pre-COVID status, people need to understand that these populations, despite our best efforts, entered this pandemic with significant health disparities, an unequal burden of disease, lower access to healthcare in a lot of different ways. And by access, I don't just mean an insurance card, meaningful access, being able to get to your doctor, see your doctor, understand your doctor, nurse, healthcare provider. So many of these populations come in at a disadvantage. And that's where we begin. And we know we're going to go back to that post-COVID. And I think that what this has really illustrated is our lack of attention to public health, our lack of systems to meet the needs of diverse populations, really kind of cracks these disparities wide open. And that's exactly what we've seen here. And in some ways, this has illustrated all the things a lot of us have known, but it has really shown a very powerful light on all these key challenges that we face. And you're right, in a couple of weeks, probably even sooner, we are going to want to invite people back to say, come, get your diabetes care, get your heart failure care, get your hypertension care, get your asthma care. And we need to make sure that we're doing that in a multilingual, multicultural way where people trust us, because the stakes are really high for them because they have the highest burden of these conditions. And so a lot of my patients who I've seen, who I used to see every 3 months with diabetes, I haven't seen now for 6 months. And I get on the phone with them, but I'm not able to check their blood work and see how they're doing. So getting them back is a real priority. And so I think the pre-COVID era identified disadvantages that were really kind of laid raw during COVID. We've tried to use this crisis as an opportunity to fix a lot of things, and so that's good news. But the question is going to be, how long will our memory be, or how bad the pre-COVID phase led to the damage that we've seen in the COVID phase? If we have a short memory, Marcela, we're going to go back to the same old. If we have the courage and the passion to say we can't forget, then we will hopefully build a new system that's more thoughtful, that invests more in community health and public health, that is more creative around using technology and other things to meet people's needs once they come to our door and to facilitate access to care.
Okay. So, well, now I'd like to turn to some questions from the audience, and I'd like to invite Chris Avello to join us. He's Director of Subscriber Experience at the Boston Globe, to join us and share some of the questions he has selected. Hi, Chris.
Hello, hi everyone. Thank you, Marcela. Thank you, Doctor. Before we go to questions, I just want to take a brief moment to say thanks to all of the subscribers and readers who are attending, watching now, and who submitted questions. We couldn't do this without you, so we hope you're enjoying it, and thank you so much. I'll start with one from Kyle. It said, how can Boston and other area residents show pragmatic solidarity with the residents of Chelsea right now?
Yeah, it's a great question, and I think I break this down in a couple areas. One is, I think what's really troubling as a healthcare professional is it's how politicized this virus has become. This isn't a red or blue virus. It's not going to require, conservative or liberal solutions. This is a virus, I think, that has made us all realize our kind of common humanity. And as such, there are very significant needs in some of our vulnerable communities, particularly around food. Food insecurity is a major issue. The individuals, a lot of my patients who worked in restaurants or other areas that are now closed are, financially in great peril. So I think there's great organizations in those places. A lot of people we find want to volunteer and they kind of come up with their idea of what they want to do. That's really wonderful. There are organizations on the ground doing great work. If we could deploy those dollars to those organizations and support particularly food insecurity right now, help with, financial sustainability. And I think those are the biggest ways in which we could show our support to those individuals. And going back to Marcela's comment around stigma, it's not just stigma that people have about having the condition. I worry about stigma that people might have at looking at places like Chelsea, at Detroit, at New York, and really challenging people to say, yes, this has become an epidemic, a pandemic of communities of color. It's not that we are more susceptible, it's that we tend to live in these social conditions that are right for the spread of this pandemic. And so for all those reasons, those are ways that we can show solidarity through our support, both moral and financial. And I'll end by saying this, these social conditions were right for the spread of coronavirus. We don't know what the next set might be. And the next set might be a set of conditions that impact suburbanites, rural individuals. We don't know what they are. So kind of saying that's a problem over there, I think is short-sighted because the next virus might spread in a different way. And I think we need to all understand our common humanity.
Thank you. So that's what individuals can do. Steve was asking, what do you think legislators can do to provide relief for the hardest hit and most vulnerable populations?
Yeah, again, I think it is about resources as well. And I think it's about, I would challenge, my hope is that my challenge to legislators would be to really study what just happened and what is happening. And think about common sense policies that could prevent these types of things to happen, to happen to all of us, not just the Chelseas of the world. I do think that there are a lot of very important things that could be done on the legislative side, around, and we're an amazing state around public health. There's no doubt. I mean, we're incredible. But the beauty of this state is that we always want to do better. And I think we can do better based on what we've learned. I think we can be better prepared for the next one. I think there are policies that could help us stabilize some of these vulnerable communities, more investments around the social determinants of health. So those are some things that we hope to engage with. And I think legislators are stepping up to this. But again, this is about how long our memory is going to be. And we need to really stay on top of legislators about this.
Thank you. And I will ask one more from our subscribers, and this one came from Gabriel. What's the single biggest lesson we've learned from the pandemic about reaching legal as well as undocumented immigrants with accurate information about a public health issue?
Yeah, I guess one of my biggest messages around all things related to immigration is that just like so many different issues that we tackle as a nation, there are political forces that aim to drive us into corners for a lot of very different political reasons. And I do believe that it is time that we as a nation stand up for a lot of different issues, whether it be gun safety, whether, immigration. When you ask people in general around these, there are a lot of common sense solutions here that we could focus on. And I think this virus demonstrates again that there's no discrimination between, this virus isn't checking anybody's documents. And this virus is spread, by somebody you're paying to clean your house. Right? So we need to be cognizant of that. And we need to respect individuals and their dignity and their desire to work and to be engaged. And around messaging, I do believe, and we had to message this quite a bit, don't be afraid, come get tested. We're not going to ask you this information. Don't be afraid to come to the hospital. It's really sad to have to continue to message this idea that, we don't want you to live in the shadows. That's not good for you. That's not good for anyone. And so that messaging is unfortunate. It's necessary. I'm hoping we have a different narrative going forward that is about us, not us and them. And I believe that around immigration and around this messaging, my hope is that we could grow from those messages. And we still need to say them now. We still need to say, we're going to be doing contact tracing and the state's going to be calling you. Don't be afraid. Pick up the phone. We're going to try to help. But you can understand how people are going to be afraid about that.
Sure. Thank you so much. I'll turn it back over to you, Marcella.
Dr. Betancourt, before we conclude, I realized that we didn't talk about contact tracing, and you did mention the program. And so if you could briefly say something about it and how is Latino participation going? I assume this is happening also in Spanish. How are people being assured that they can participate and that their privacy is going to be preserved, et cetera?
Yeah, so just a word about what contact tracing is. If you are found to be positive, you will get a phone call, and that phone call will aim to identify individuals you have been in contact with 48 hours prior to your first symptom, not when you were tested. And the idea here is that, and it's much easier done now, hopefully, because we're engaged in more social isolation and our contacts are less than than 6 months ago, where, in any day we could have contacted a whole bunch of people, but it's less now. That in that moment, you're able to identify the 4 or 5 people, and then you talk to them and you give them the advice or provide them with resources to isolate themselves, and you begin to put out these little fires. That's what contact tracing is. The state has engaged Partners in Health that has a long global history doing this very effectively for different pandemics, including Ebola and others. So it's a tried and true and proven strategy that we will be deploying here. Now, we just have been in conversations with them this past week. They are just getting started. They are just kind of getting rolling. They're starting to make phone calls. There are going to be bumps in the road and growing pains as we do this, but this is going to be critical to get us back to some path towards normal. is going to be contact tracing. It's going to be that and testing, and the solution is a vaccine. And so ultimately, that contact tracing process is going to be done in a multicultural way. I just writing some op-eds in English and in Spanish. We're doing some videos, working with different partners at the state level and multicultural marketing partners there, ASG and others, to really help make sure this is done in a culturally competent way, because we don't want people to be left behind. And we do believe that as we kind of come out of this curve, that contact tracing is going to be essential to prevent these brush fires from developing. So I guess my word out to everyone is just to, if you do get that call, answer it. We're working on all the particulars, but it's an important effort and an important part of this process.
And it is being done in Spanish, right?
Yes.
If people are not answering, it may be because they don't recognize, or they may not understand the message, or.
Yeah, and that's going to, again, goes back to our earlier conversation. We need to create very strong messages to the community. When you see mass COVID on your phone and it pops up, we'd like you to answer that call. And we want to let you know also that your identity is going to be protected here. I mean, our goal is a public health goal here. So I think people are afraid, right? I get this phone call from mass. Am I going to be traced? What does this mean? Stigma, again, as you mentioned. So we want to create that message to get people engaged in contact tracing. I think it's going to be very important. It's going to be done in multiple languages, I believe, like we've tried to do a lot at the state and city level.
Just briefly before we finish, just want to acknowledge some of the comments that have come in that, people saying is really not so much about stigma, but their inability, and I think you mentioned this, and it's absolutely true, the inability of this working class population to stop working. I mean, because frankly, they don't have access to paid sick leave. So one day of, that they don't work is a day that they don't receive a salary for, and they mostly live day to day. So more than stigma, I think the message from some of our commenters is, or some of our attendees here, is that it's all this, the safety net that they have that is not as strong as we may wish them to have it. So, which is why I think your message to the legislature, to lawmakers, to strengthen those social networks for these populations particularly important, because it's really the fact that they cannot afford to lose a day of work. They cannot afford to go sleep somewhere else because they don't have anywhere else to isolate themselves. So just wanted to acknowledge that from some of our attendees. Any closing words, Dr. Betancourt?
Yeah. I guess I want to say one thing. Chelsea's got a lot of focus, but when we look at our top 10, it's Chelsea, it's Lawrence, it's Brockton, it's Lowell, it's Malden, it's Revere. It's the bottom line is that we've talked about Chelsea a lot, and I hope that Chelsea itself doesn't get stigmatized. I mean, I think Chelsea has been the canary in the coal mine in a lot of ways, but I guess what people need to understand is that these are hardworking people who are trying to make a good life for themselves. They play a key part of our economy, a key part of our society. And I think this conversation about immigration, about Chelsea, really gives us a lot of lessons that are applicable to all of us. And so, it's been a pleasure to be here with you. I think we are going to learn a lot. I certainly am going to stay very active to make sure that our memory isn't short. We here at Mass General are very, very committed to communities like Chelsea and others, and Partners Healthcare committed to the greater Boston area. And we will continue to try to do better. And I know we will get out of this. And on the science side, we have scientists who are working diligently on more testing, on vaccines and the like. So I have faith in where we are. And I'm thankful too. We saw pretty horrible visuals of what happened in Italy, what happened in New York, what happened in other parts of Europe. And I could say thankfully that due to our planning as a state, and yes, this was very uneven, and what happened in Chelsea and some of these other communities were tragedies. But, we, despite all that, never got overwhelmed in the healthcare system, thanks to people being, responsible. And hopefully we can, in the next one, give people responsible options when just being responsible isn't possible due to your social conditions.
Sure.
So thank you for all you do. Thanks to the Boston Globe for hosting these important conversations. And thanks for all who participated today. And we hope to engage you in supporting Chelsea and in these efforts around equity in health and healthcare in the future.
Thank you, Dr. Betancourt, for your insight and your valuable work. And thank you, everyone, for joining us today for this Globe Up Talk. Please let us know if you have any feedback or ideas for future conversations. We would love to hear them. We also welcome you to visit Globe Opinion and read more of our varied perspectives on the coronavirus pandemic. And we also kindly ask you to join us for our future Up Talks. The next one is this Thursday, May 7th, on Thursday at noon, with Robin Chase, who is the founder of Zipcar and an urban transportation visionary, who is going to be talking about how we should reimagine cities after the pandemic. Thank you so much. This concludes our Up Talk today. Bye-bye.
Thank you.